Good morning. My name is Ashley Crawley, and I'm an MD and PhD candidate from the University of New Mexico. I want to sincerely apologize for not being able to present this project in person, but thank you all for this opportunity nonetheless. So today I'm going to be discussing the evaluation of a new cervical cancer screening guideline in Veracruz, Mexico. Next slide. So cervical cancer is currently the third most prevalent female cancer worldwide. It accounts for about 500 cases annually and about 200,000 deaths each year. Of note, however, 87% of these cases are occurring in developing countries. Next slide. Currently, cervical cancer is the second most common type of female cancer in Mexico. As a nation, Mexico has made tremendous progress in the cervical cancer burden. In the last decade, they have reduced their standardized mortality rates in half. However, some areas within Mexico are still seeing high rates of both cervical cancer diagnoses and death. Specifically, the southern region of Mexico sees a much higher burden than the northern region, with a relative risk that is almost 3 times higher. The southern region is where we focused our efforts in Veracruz. Next slide. So cervical cancer in Veracruz, the age-adjusted mortality rate of cervical cancer in 2008 was 19.9 per 100,000 women. This was 50% higher than the national average, and with a relative risk almost 2 times that of the rest of the country. Clearly, this part of the country is still struggling with the burden of cervical cancer. Some proposed explanations within the literature included the rural nature of the state leading to access barriers, the infrastructure in place, and the lack of knowledge about both cervical cancer and screening itself, including the pap smear. Next slide. So cervical cancer screening. Traditionally, cervical cancer screening has surrounded the pap smear. The pap test was discovered in the 1940s, and it involves removing cells from the cervix and then examining them for signs of cancer. This was a screening test that effectively detected precancerous or cancerous lesions and led to both early treatment and drastically reduced both the morbidity and mortality in many developed countries. While the pap smear is extremely effective, it does rely on multiple healthcare visits. So translating this successful screening program to more developing nations poses a serious challenge, especially in areas that suffer from different infrastructure and different healthcare beliefs. We could have an entire presentation on the alternatives to pap smear, but for this presentation, HPV has recently been shown to be a cost-effective alternative to pap smear screening alone, and a study particularly was validated with HPV testing cost-effectiveness in Mexico. Next slide, please. So, in 2008, HPV testing was officially incorporated into Mexico's already existing national cervical cancer screening program. This new guideline recommended that women between the ages of 35 to 64 be tested for HPV testing first, and positive tests would be immediately referred to colposcopy. In 2009, this program expanded to 21 states, and one of those included Veracruz. Next slide. So with the epidemiology background, as well as this new screening guideline, clinicians and healthcare professionals in this region of Mexico reported that they were frequently seeing women presenting for cervical cancer screening and subsequently getting diagnosed with advanced stages of dysplasia. They also reported that women were presenting for screening for the very first time at older ages than were particularly desired. And many women reported that the pain from the procedure, the pap smear itself, was a deterrent. This is of particular importance because cervical cancer screening aims to identify early stage dysplasia where there is a higher survival rate. Stage 1 has a 5-year survival rate of 85% as opposed to stage 4, which is at 7%. So not only does it matter how many women are being diagnosed and how many are being screened, but at what age we're able to catch their diagnosis. Next slide, please. So the overall goal of this study was to evaluate the impact of this new HPV screening guideline for cervical cancer in Veracruz, Mexico. Specifically, we wanted to compare the incidence of cervical cancer before and after the implementation. We wanted to compare the incidence among cervical cancer stages before and after 2009 when that implementation was put in. We wanted to evaluate the age distribution, and finally identify if rural versus urban place of residence was significant. Next slide, please. I want to emphasize that the majority of our time spent on this project was really collaborating with this community. This was the first time a CEESP student had been in Veracruz specifically. So we spent a lot of time collaborating with multiple individuals and identifying a strong research question that their community was supportive of. I have the opportunity to work with local physicians in the area, clinicians from the University of Anáhuac, which is a private medical school in Veracruz, as well as public health practitioners and epidemiologists through the State Health Department. This project obtained IRB approval from my home institution of the University of New Mexico, as well as a letter of support from the Veracruz Health Department. For our data source, fortunately, Veracruz had a robust cervical cancer screening department in place that oversaw a database collecting cervical cancer cases, where we obtained most of our information, and we utilized information from the Veracruz census as well. Next slide. This study included all cervical cancer diagnoses from the years 2005 to 2013. However, cases that were missing information on either age or stage were excluded from our analysis. Most of the variables that were given were translated from Spanish for ease of interpretation. For staging of cervical cancer was categorized using the traditional FIGO system that we use in the United States as well as many other areas. Age categories, incidence, and a before and after implementation category was created. And then most of our preliminary analysis is shown using a graphical representation. Next slide. So these are our very preliminary findings at this time. This is a graph of the before and after periods of the HPV implementation, and as you can see, the mean incidence appears to be lower in the time period after HPV implementation. Because this is a retrospective study, this could be for a variety of reasons, HPV testing, other things in the community, but with that change in incidence could potentially warrant further investigation. Next slide, please. This is a graph of the incidence by cervical cancer stage. So this data is a little bit inconclusive, but it does show that stage 1, stage 2, and stage 4 types of cancer seem to have a higher incidence in the after categories, while stage 3 and the recurrent types of cancer seem to be lower. Some have inferred that HPV testing could have a positive impact on identifying cases in earlier stages, but again, these results are very inconclusive. And further work does need to be done to evaluate specifically why the stage 4 types of cases seem to increase. Next slide. This graph is a little bit harder to read, but when evaluating the age distribution, overall the percentage within each age category has been consistent. However, we do see a slight increase in cases in the 30 to 39 age group, while a slight decrease in the 40 to 49 age group. These are age groups that are specifically affected by the new HPV testing. However, it also appears that in the age categories 50 to 59 and 60 to 69, there's also been an increase. So again, this data is quite inconclusive as to whether there has been a change in the age distribution with this new screening implementation. I want to emphasize that these are our very preliminary findings at this time. I have been working with the Veracruz Health Department consistently over the past couple of months to continue to fine-tune these variables, and we hope to continue to fine-tune them as well as get more beneficial data so that we can continue this analysis. Next slide. So some of the limitations of this study. Number one is an incomplete data set. There were multiple variables that were missing, specifically a portion of the cases that were missing, the geographical location was too high to complete an effective analysis. In addition, we were provided with some information about whether those who had been diagnosed with cervical cancer had had a pap smear in the past. However, this was only information provided for 20% of the cases. So again, it makes it very difficult for us to complete an analysis in that way. As I mentioned previously, this is a retrospective study, so we cannot really infer any type of causal relationship between HPV testing and these changes in cervical cancer incidence. And finally, for the incidence categories, we use the denominator of the total population of women in Veracruz for each year. This is what we had to work with, but a more accurate value would really be to identify the number of women at risk, or a separate analysis would be the number of cases versus the number of women screened. So there's definitely some improvement there. Next slide. The Veracruz Health Department has an extremely motivated department that would like to continue working both with the CEESP program and provide further analysis. Some of the proposed projects would be one, to evaluate the HPV screening rates, and then specifically how those diagnosed with HPV are being translated to colposcopy and who's being lost to follow-up, as well as subsequent treatment. This could really help to identify the structural barriers that women are facing. Factors such as geography, socioeconomic status, race, and education could shine light on the issues and help for more targeted interventions. Many of these variables are not being collected through their database at this time. And eventually, identifying and looking at the impact of the HPV vaccination, as particularly because this community advocates for that vaccination. Next slide. So for my career plans, I'm currently in my last year of medical school and in the process of applying for a residency in obstetrics and gynecology. I'm also finishing my Master's of Public Health this year, and will actually be using this project for my professional paper. So there will be a lot more work to be done throughout this year with this community and seeing where we can take this analysis. And then overall, I really hope in the future to continue to investigate public health questions and incorporate those into clinical practice. Next slide. I first and foremost want to thank the CEESP program for this opportunity and allowing me to go to Veracruz. I want to thank Dr. Solomon and Dr. Chamberlain for all of the advice that they've given me in helping me to set up this project. I want to thank Dr. Armando de Alba. He was instrumental in helping us create these connections in Veracruz and to help this project continue to move forward. I want to thank the Veracruz Health Department, the Secretaría de Salud, the University of Managua, and my own advisor here at UNM, which is Dr. Christine Tolstra. And with that, I will take any questions that you guys have.
Thank you, Ashley. Questions, comments for Ashley?
Hi, Ashley. Can you hear me?
This is Dr. Stacy Fed.
It's a little hard to hear you.
Okay.
Can you hear me now?
Yeah, I can hear you now.
I had a question if you were planning on looking at cervical cancer incidence by individual year, because I think in other studies that I've read, they've actually noticed an increase in incidence kind of in that initial year of the screening program, just because they're picking up a lot of prevalent cases. So I was just interested to hear if you were planning on looking at it to see if you see that bump in 2009.
Yeah, so that's a great point. I did do the analysis per year, and it looks a little funky. There was a lot of increase from 2005 to 2008, and then initially in 2009 it dropped back down, and so, but then in 2012 and 2013 it seems that the cases are going back up, and so my question is also how long it's actually taken them to implement this into a community that's relatively large and relatively rural. So I could potentially see that those increases later on are from the implementation of HPV testing, but again, it really hasn't been long enough, I think, to tell.
Can I ask a question? This is Joe O'Donnell from Dartmouth. Tell me what's the uptake of HPV vaccination in Veracruz these days?
So I believe there's actually a CEESP student who's doing a project on that, but it's very high, very, very high. they have implemented, interestingly, they're actually only giving the vaccination to girls right now. And I don't want to overshadow Mariela's project, which is about HPV testing in Veracruz, but from my perspective, it's actually a very, very high rate of uptake, and so it's going to be very interesting to see the impact of that.
Thank you. Dr. Wilson.
Very nice presentation, thank you. I'm glad you mentioned the denominator problem. This is a big one for you. And your approach, I think, is a good one. You might think about doing some interpolation with existing census data or finding some other denominator sources, because that's really critical. You also mentioned missing variable data. Not much you can do about that, but what about missing cases? Do you have any sense of entire cases missing, and how might that influence your results?
You know, that's a great point, and I think they've had this database for about 30 years, and so I think it's a relatively effective process on how they're referring these cases to the database. But the truth is, I actually don't know, and there's a good chance that we may be missing very critical cases who are diagnosed or miscategorized for metastases. Who knows? So again, we could be missing a lot of cases in the past, and that could skew the data.
If they're consistently missing, that's okay, but it's
Yeah.
Okay, great.
Very true.
Thank
Hi, Ashley. This is Bob. It's good to see you.
Hi, Dr. Chamberlain. Good
What?
to see you too.
Yeah, one of the things that's common in Mexico is the treatment of Mexicans who go to the United States.
Yes.
So if I'm riding on a plane from Mexico City and I'm talking to someone in the next seat, and they say, "Well, I'm going to Houston," you know, my question is, are you going shopping at the Galleria, or are you sick? And so it is so common that those who can afford to seek care in the United States, that you may be missing some upper income patients.
Definitely.
And that's very hard to estimate. But I know that the MD Anderson Cancer Center, where I was for 25 years in Houston, has a very high number of Mexican patients. So that's something to consider, and I don't know how you'd get a handle on it.
I'm not sure either, but I totally agree with you. As someone who's training in the medical field in New Mexico, we see that very real as well.
Other questions, comments for Ashley? Okay. Thank you, Ashley. We are sorry to miss you today, and we look forward to seeing you again. We'll be in touch.
Awesome. Thank you so much.
Thank you.